today's webinar hosted by the NITAG Sport Hub based here at the University of Cape Town. I just want to welcome all of you who have made the time to join this webinar, and also specifically to welcome our partners, in particular within the WHO stable, who will have some pointed and leading talks to give today. I'm just thinking that a few years ago, I was talking to a high-ranking member of WHO who was then retiring, and who pointed out that, following the end of the Second World War, almost half of WHO at that stage was probably involved in the area of malaria prevention, malaria research, and so forth. And over the next decades, the number of people who were involved in malaria-related areas slowly dwindled, almost as if people saw very little hope within the malaria response stage. We do know that some years back, I think this must have been 2015 or so, that Tuyoyo was awarded jointly the Nobel Prize in physiology or medicine for the work that she had done in artemisinin-based responses to malaria, as a huge breakthrough that has been hailed as having saved millions of African lives. Now, that was really an exciting development. But to be honest with you, for some of us who believe that for poor areas such as our continent it is prevention that still weighs much more than responses to disease when disease have occurred. It is why I just a few weeks ago, when we met the RITEC meeting in Congo-Brazzaville, one of the really great groundbreaking highlights was the language that we could use with respect to malaria, where for the very first time, after literally thousands of years of populations such as our own suffering from malaria, that we really realized that we now have a glimmer of hope for preventing both mortality and morbidity in the populations that are primarily our concern. So it's a really great pleasure as I welcome you here today to this time that we should actually realize is unprecedented and should really fill a lot of our countries within our area, within the African continent, with hope. So welcome to our 7th webinar that will be looking at the malaria vaccine introduction space. Please just remember again that you can put in questions and answers in the chat area. And also just remember that we have the ability here for you to choose. If you look at that sort of globe picture under your screen, next on the right of the raise hand button, that you are able to dial into other languages other than English. You can choose French or Portuguese if you need a language translation. So thank you very much again. And as we continue, I'll hand over to our colleagues in WHO with Mgawa starting with the progress in RTS vaccine introduction within the African space. Thank you and welcome again.
Thank you, Ruzan and the organizers. Hi, everyone. My name is Mgayo Magaf. I'm a technical officer on the malaria vaccines program, and I'm based at the region office for WHO in Brazzaville. So it's an honor for WHO to have this opportunity to share updates on the malaria vaccines. I remember the last time we were on this platform, we were talking about one vaccine, RTSS, And now we have it in the plural form, vaccines. We have a second vaccine which has been recommended by WHO for use to prevent malaria. And so we have a lot of updates because it's been a while ever since we shared these updates. So together with me is Lindsay Wu and Rafik Okain. And the fourth one is Elian Farr. And we will present different parts of this presentation of these updates. So this is the agenda. This is the outline of our presentation. We're going to start with the progress that has been made on RTSS vaccine, its introduction in Africa, covering the first 3 countries. We call them MVP countries that started to implement it in a pilot, and then covering plans going beyond non-MVP countries. We will also cover R21, the new vaccine, which has just been recommended, and you will be taken through that by my colleague Linz. And then that will be followed by the updated WHO recommendation. After having the second vaccine, WHO updated the recommendation, and that will be presented by Rafiki Okain, and then lastly, implications of R21 on malaria vaccine introduction in Africa by Elian. So the progress of the implementation of RTSS in Africa. So you may remember that the implementation of the RTSS malaria vaccine started in 2019. So it's been more than 4 years now, ever since it started in the 3 pilot countries, Malawi, Ghana, and Kenya. Following the first recommendation that was issued by WHO in 2021, the 3 countries expanded the implementation of the vaccine into comparator districts. So initially in 2019, the implementation was in MVP initial vaccinating districts. The comparator districts were not administering the vaccine. After the recommendation, the MVP comparator districts started administering the vaccine at different times. Malawi started in November 2022, and that was followed by Ghana in 23 February, and then Kenya was the last one to implement the vaccine in comparator areas in March 2023. So the maps are showing you the implementing areas, MVP areas, and non-MVP areas as well. So those that are colored shaded green, those are the districts or counties for Kenya that started in 2019, while the pink one are comparator districts or counties, and the rest, which is not shaded, is the non-MVP counties or districts. Now, where are we at the moment? The program is progressing very well, and it's expected to end in December this year. So it is going to close out on the 31st of December. Over the time that the ministries have been implementing this vaccine, up to October this year, they have reached more than 2 million children. And that's the number of children who have received at least 1 dose of the malaria vaccine in those 3 countries. Now, the number of doses that have been administered in the 3 countries is more than 6 million. So the program has reached a good number of children, and it progresses well. So this one is showing the immunization coverage in the initial implementing areas in the 3 countries. On top, you have Malawi, in the middle you have Ghana, at the bottom you have Kenya. The two, the tables and the graphs are basically showing the coverage and as well as trends in terms of coverage in the three countries. The broken red line that you see represents the target population that is on the graph side. And then the green curve is representing Penta 3, while the deep blue curve represents the coverage for RTSS1, the blue one for RTSS3, and then the gray one is for the fourth dose, which is RTSS4. Now, if you look at the average coverage for the years for the three countries, 2020, 2021, and 2022, and then the last one is for this year, covering the time from January to September. And this is to compare the coverage for the different years that the program has been implemented in the three countries. If you look at the table for Malawi, you will see that the country has maintained good coverage over the years, but there is sort of stagnation this year. If you consider the data that we have, that is up to September, there is a slight decrease in terms of coverage, but we still have 3 months to cover the year. So we hope that the coverage may be better for the remaining month to maintain the same level. I should say that the coverage for the fourth dose, which is 47%, has been a bit low, but we now understand that even for the other vaccines that are given in the second year of life, there has been no much difference. If you look at the curve for Malawi, there has been some challenges in the country, natural calamities, tropical storms that begin from the Indian Ocean, then they have landfall in Mozambique, then they cross the country into Malawi, affecting health systems there that affected coverage in different times of the year. If you go to Ghana, Ghana started at high point, and they have maintained the same high coverage. If you look at the averages there for the 3 years, ranging for RTSS1, 71% up to 77%, which is very good. And the average for this year, the averages for this year are even better than even the averages for the previous years. I should point out that the coverage for the fourth dose is excellent for Ghana, 83%. And the reason for that is that initially they were administering the fourth dose at 2 years, at 24 months of age, and they changed that around April this year to 18 months of age to coincide with the administration of MCV2. And as you can see on the graph there, you see a significant increase around April 2023 of coverage in the fourth dose there. That is the reason why Ghana managed to improve significantly the coverage of the fourth dose. Again, there were challenges. There have been challenges in Ghana as well, stockouts due to different reasons. First one was due to COVID-19, which affected the supply chain and the issues related to procurement and shipping of vaccines and other materials and supplies. And then there were stockouts not affecting the malaria vaccine, but other vaccines that affected the coverage of the malaria vaccine as well earlier this year. And you see them circled in broken red circles there. Now for Kenya, Kenya started with an expanded age of eligibility. So they were going, they were vaccinated in the beginning, children from 6 up to 1 year. And so they had really a huge number of children to cover, sort of catch up in the beginning. That's why you see that peak in the beginning with respect to the coverage of RTSS1. When the pool of children was covered, the coverage came down to where it's expected to be. And they have maintained good coverage, as you can see, moving hand in hand with the coverage of Penta 3, which is excellent. And they have maintained that ever since. Very nice coverage, and it's the same for this year, which looks to be better than 2022. They also had some challenges. They had health worker strikes, especially in 2020 and 2021. I should also say that this year they conducted a PIRI, intensification of routine immunization activity in the country. And as you can see at the end of the graph there, there is a peak in coverage involving all the doses. That is because of the period that they held this year. Now, during the implementation of this program, the evaluation component of the program sought to understand if there was any effect of the vaccine on the use of ITNs and the care-seeking behavior in the areas where the vaccine was being implemented. And to understand that, a household survey was held. They were household surveys that were held. And from the one that was held about 30 months post-introduction, the results show that there was no change in the use of ITN after the introduction of RTSS. As you can see on the left side there, the bars, the graphs are showing the proportion of children who were using ITNs the night before who used ITNs the night before the survey. And the numbers are percentages for the three countries, Ghana, Kenya, and Malawi. And the comparison is made between the implementation and the comparator areas. For Ghana and Kenya, you don't see a difference. For Malawi, there was a change in ownership and the use of nets, and it was during, after a campaign of ITNs was conducted. But again, the results show that there was no difference between implementation and the control areas in those areas. Regarding care-seeking behavior in children reporting fever, again, there was no significant difference in care-seeking behavior in the children reporting fever in the past 14 days preceding the survey. So there was no really negative effect of the introduction of the vaccine on the use of ITNs and the care-seeking behavior. The other thing that the program sought to understand is whether the introduction of RTSS had any impact on the coverage of other EPI vaccines, other antigens, okay, by study area or over time. And so, as you can see here, we have all the three countries with the coverage indicated for the different antigens that are being implemented in those three countries, and a comparison between implementing and the comparator areas is again being made. And there was no difference in terms of coverage. And so the vaccine did not change the coverage of other EPI antigens by study area or over time. So we now have results from the pilot covering a duration of 46 months of implementation. And the results are very good, as you can see here. The vaccine has been confirmed to be safe with no evidence of any safety signals that were detected during the phase 3 trial. and there are no new safety signals during the implementation of the pilot that were detected. The vaccine has been shown to have high impact during these 46 months of implementation, 13% reduction in all-cause mortality, excluding injury. And this is additional impact on top of that, which is provided by ITNs and IRS and other interventions in place. This impact has been measured in children who are age eligible to receive the vaccine, with the coverage for the fourth dose ranging between 64 to 75%, and that of the fourth dose ranging from 33 to 44%. What does this tell us? If we improve the coverage of the vaccine, the different doses of the vaccine, then we more likely going to see higher impact than what we see at this coverage. It is also feasible to introduce the vaccine with high uptake, as you have seen in the preceding slides, with no reduction in ITN use or care-seeking behavior or uptake of other vaccines. There is high demand by community and acceptability by healthcare workers. In terms of equity, the vaccine delivery is equitable by gender or socioeconomic status and the extent reach of preventive tools in the areas where it's being implemented. Now, to make the equity point clear, this diagram serves that purpose. Now, this comes from Ghana, but similar results have been replicated in Malawi and Kenya. So it comes from the household survey after 30 months of vaccine introduction, and it's capturing ITN use and RTSS in children who were aged 12 to 23 months. Now, if you look at the this brown, okay, the brown part of this diagram, which is indicating use of ITNs, 61% were found to be using ITNs, which means those that were not using ITNs were 39%. Now, those who had been vaccinated with at least a dose of RTSS were 85%. Those who were using both interventions were 52%. And the point about equity comes in here, that those who were not using ITNs, 84% had been vaccinated. So they had, even though they were not protected by ITNs, they had another tool, the vaccine, with them for protection. Of course, the emphasis is that all available interventions should be used. So the vaccine is implemented in the context of other malaria prevention measures. 6% didn't use ITNs and were not unvaccinated. So this is a group that we want the countries should be reaching to make sure that they are also protected. Now, where are we now regarding the expansion of the vaccine into non-MVP countries? So as of now, more than 30 countries in Africa have expressed interest in introducing a malaria vaccine. And since the opening of funding window in mid-2022, GAVI has approved applications from 18 countries to introduce vaccine in routine immunization programs. And those countries are Benin, Burkina Faso, Burundi, Cameroon, Central African Republic, Chad, Congo DRC, Ghana, Kenya, Malawi, Niger, Nigeria, Liberia, Mozambique, Sierra Leone, South Sudan, Sudan, and Uganda. In July this year, the first supply allocations were confirmed for 12 countries, and those countries are the ones that you see above in bold. for the introduction in phase 1, and those phase 1 areas of greatest need. And that is based on the allocation framework, which was developed by a group of experts convened by WHO. Now, speaking of the framework, here is a test of what the framework means. And so the framework is based on certain principles. First is to allocate the vaccine to areas of greatest need, where the malaria disease burden in children and risk of death are the highest. And there is the solidarity principle, which states that no country should receive more than 1 million doses per year. Now, the areas of need were categorized into 5 categories. The first category represents where the needs are highest, greatest need. And it was developed as an index from 2 indicators. The first one is the indicator for malaria transmission intensity, represented by either prevalence of the disease or incidence. And the other one is all-cause mortality, or under 5-cause mortality. And so the two are combined to give different categories, an index, which gives different categories, including which are category 1, areas of greatest need, and the last one is category 5, where the needs are lower compared to the categories above. Now, stratification, this is Cameroon representing the process, how it was done. And so the areas were stratified by category of need, as explained by the framework. And the country, therefore, is now subdivided into different categories of need, as you see there in the middle part of the slide. And then the target population in those categories is then determined. For Cameroon, category 1 was almost 700,000 children. Now, the vaccine is given, in a schedule of 4 doses. If you take that number, almost 700,000 children, you multiply that by 4, then you find that the number goes well beyond 1 million. And that takes you back to the solidarity principle that no country to receive more than 1 million doses per year. And so countries that found themselves in such a situation, they were asked to prioritize again the areas. And Cameroon did that, and using their own criteria, they did that. And they ended up with a target population of about 250,000 children. And that is in 42 districts, 42 districts out of the 200 districts in the country.
Mugawa, sorry to interrupt. Just to be mindful of time, I think you've gone a little bit over your time. How much more time do you need to finalize?
I am finalizing. I'm winding up.
Okay, great.
So preparations for the malaria vaccine introduction are currently underway. Cameroon has just received its first shipment recently, and they are now preparing for introduction. Learnings from the pilot program are included in the technical guidance to the countries, and it's available to the countries. Availability of 2 WHO recommended malaria vaccines is expected to increase the supply and to meet the high demand from the countries. What you see on the right side is an official of the Ministry of Health in Cameroon announcing the receipt of the first doses in the country recently. So that's all from me. We now call upon my colleague Linz to take you in the next part of the presentation. Linz, over to you.
Hi, thank you, Mugaiwa. I'm Lindsay Wu. I'm a technical officer with the WHO malaria vaccines team. As Mugaiwa mentioned, R21 was the second malaria vaccine to be recommended by the WHO, and this happened in just October this year. And it was 2 years after the first malaria vaccine, RTSS, was recommended in 2021. Next slide. In terms of the technical characteristics of the vaccine, R21 is very similar to RTSS with regards to its mechanism of action and its indication. It's a pre-erythrocytic vaccine used to reduce P. falciparum malaria, and the target population is also infants and young children. It has a similar vaccine construct and adjuvant to RTSS, so it's a virus-like particle, and it's also formulated with the matrix M adjuvant, which is a saponin-based adjuvant, very similar to the AS01 adjuvant that's used with RTSS. And finally, it also has a similar dose schedule, which is a 3-dose primary series with each dose given 1 month apart, followed by a 4th dose given 12 months later. And R21 can also be given either seasonally or age-based. There were several groups involved in the evidence review for R21. The first key group was the SAGE MPAG working group on malaria vaccines, which was co-chaired by Eusebio Masete from Mozambique. And this group had an initial review of the data in March 2023 of this year. And when the phase 3 trial for R21 had finished meeting the primary endpoints and provided the data to WHO, the working group then conducted a full evidence review at the end of July. And then in parallel, an R21 safety working group was formed to have a detailed review of the safety data. And this group included members from the African Advisory Committee on Vaccine Safety, AACVS, as well as members of the R21 DSMB. And this working group presented their findings to the Global Advisory Committee on Vaccine Safety at the end of June this year. Then SAGE and MPAG held a joint session at the end of September, and soon after, the WHO Director General endorsed the inclusion of R21 into the existing WHO recommendation for malaria vaccines. And then finally, WHO pre-qualification has been ongoing since Q1 of this year, and we expect the process to be completed very soon. So the WHO evidence review was primarily based on data from the R21 phase 3 clinical trial. This was a multi-center trial with a total of 4,800 participants that were aged 5 to 36 months at first vaccination, and it was conducted in 5 sites across Africa. The study tested 2 different administration approaches. The first was a seasonal administration in 2 sites in West Africa, and that's shown here on the map. And then if you just click once. The second was an age-based administration in 3 sites. 2 of those sites were in East Africa, Kenya and Tanzania, and then 1 site was in Burkina Faso and West Africa. So in all of the West African sites, seasonal malaria chemoprevention, or SMC, was provided as a standard of care by the Ministries of Health, so not part of the trial itself. And 1 West African site, Dande, the participants received an age-based vaccination, but it does have seasonal transmission, and SMC was provided as standard of care there. And then in all of the sites, insecticide-treated nets were provided to the participants on enrollment. In this diagram, we further illustrate the dosing schedule for the different vaccine administration approaches. So in this one, we show the seasonal administration. 3 doses are given just prior to the malaria season, and the malaria season is shown in the pink shaded area. And during that season, that's when the SMC is provided by the Ministry of Health. And then a 4th dose is given 1 year later, and that's also just before the malaria season. The primary endpoint was vaccine efficacy against clinical malaria. That's shown in the pink text at the bottom, and that was 12 months after dose 3. And additionally, at the time of the evidence review, there was also data available up to 18 months after dose 3. That's also 6 months after dose 4. And that was also considered as part of the WHO recommendation process. Next slide. So this diagram shows the age-based schedule where the children are given the 3 doses, each 1 month apart, and then received a 4th dose 12 months later. And in this schedule, the doses were not given based on timing with the malaria season. Next slide. In terms of transmission intensity, these graphs show the monthly rate of clinical malaria by study site and study arm in the black lines. And this helps to show the seasonal or perennial pattern of malaria throughout the year. In the top row are the seasonal vaccination sites, and these were moderate to high transmission. And then in the bottom row, we show the age-based vaccination sites, and these range from low to moderate transmission. And these graphs also help to show the timing of the doses with respect to the seasonal malaria peaks. In the blue bars is the number of participants in each month who completed 3 doses, and the green bars show the number of participants receiving the 4th dose. Next slide. This slide summarizes the overall vaccine efficacy findings by vaccination strategy. So in these rows, the efficacy of the seasonal sites combined are in blue, and the age-based sites are in red. The filled squares are the efficacy 12 months after dose 3, and the empty squares show a similar level of efficacy 6 months after dose 4 for both vaccination schedules. And these additional rows show the efficacy by study site. So compared to the West African sites, the efficacy was lower in the East African sites. This is Bagamoyo and Kilifi. And both these sites have a perennial transmission and received age-based vaccination. You just click, I think, 3 times. Yeah. So other findings were that there were no differences in vaccine efficacy between boys and girls. The efficacy was slightly lower in the younger age group of 5 to 17 months compared to the 18 to 36 months, but with overlapping confidence intervals. And then finally, the efficacy appeared similar when stratified by the number of chemoprevention rounds received, but it's very difficult to draw conclusions on the effect of the SMC due to a number of limitations in the data. So overall, R21 showed quite high efficacy when the vaccine is administered just before the transmission season. 12 months after the first 3 doses, the efficacy was 75%, and this is when the vaccine is given alongside SMC. So with the caveat that the 2 vaccines have not been directly compared in a head-to-head trial, RTSS does show a similar level of efficacy when given seasonally with SMC as well. This is based on a separate study in Burkina Faso and Mali by London School of Hygiene and Tropical Medicine. The data for this study is shown on the right. So where you see the 12-month efficacy of RTSS plus SMC in blue is 72%. And then right next to it in red is the 12-month efficacy of R21 plus SMC, which is 75%. And there's also data on RTSS seasonal administration at follow-up of 3 years and 5 years. But for R21, this duration of protection is not yet known because the participants have not been followed up for this long. Next slide. R21 also showed good efficacy when administered in an age-based schedule, although slightly lower at 66%. And this was evaluated only in low to moderate transmission settings. R21 has not been tested in a high perennial transmission setting, but it is expected to have a similar impact as seen with RTSS, given the similarity in terms of the vaccine construct. It's very important to note that the 2 vaccines have not been tested in a head-to-head trial. So based on the currently available data, we can't determine if one vaccine performs better than the other. The 2 phase 3 trials tested the vaccines using different schedules, different transmission settings, and also different follow-up times. So here I'll explain a bit more about that. So in the age-based vaccination, the phase 3 trial for RTSS included sites in low, moderate, and high transmission settings. And for R21, it only included sites from low and moderate transmission. And this is important to note because the data from the phase 3 RTSS trial showed that efficacy can vary substantially between transmission settings. Finally, there is also additional data from the RTSS pilot program at 32 and 48 months. And for R21, it hasn't been followed up for this long, so there's no comparative data at those time points. Next slide. So this slide further illustrates the efficacy by transmission setting. So this shows the RTSS and R21 efficacy by study site in order to see the data grouped by transmission. So in the first column on the left, it is the individual study site efficacies for the study sites that have low to moderate transmission. And then in comparison next to it in red, we see the R21 study sites with a similar transmission intensity, and they have a comparable level of efficacy. And then in the third column in blue are the RTSS study sites in high transmission, and you'll see the overall range of the efficacy is a bit lower. And R21 did not test age-based vaccination in a high transmission setting, so there's no comparable data there. Next slide. So in this slide, I'll speak a little bit more about age-based vaccination in a moderate transmission setting. One of the reasons we see a bit higher efficacy in seasonal administration is that this approach leverages a period of highest protection provided by the vaccine by matching it with the period of highest malaria risk. So vaccine efficacy does begin to wane after the primary series for both RTSS and R21. And that's one reason why we see an improved vaccine efficacy when we use a seasonal delivery for both the vaccines. So while there's no data on age-based vaccination for R21 in a high transmission setting, there is data from Dande, Burkina Faso, which is seasonal, but a moderate transmission, and it gives us some insight into potential duration of protection. So this graph shows the timing of doses in Dande with respect to the season. The doses were not timed to the season, so the primary doses shown in blue were actually given throughout the first transmission peak rather than before the transmission. And then the second malaria season begins before most children received the fourth dose, which is shown in green. And at 12 months post-dose 3, the efficacy we saw was actually still quite high at 74%. So while this is only data from a single study site, it provides some limited indication that there may be a maintenance of protection 6 months after the primary series in a moderate seasonal transmission setting. Next slide. So just to highlight some additional data from to complement the phase 3 trial data, the modeling suggests that there's also potential for a high public health impact in a range of transmission settings. And the cost effectiveness was found to be comparable to other malaria interventions. There were no major safety concerns that were identified that would warrant a delay in the recommendation of R21. And in addition to the similarity of the vaccine construct, the target population, and the delivery strategy, we think that R21 might have a similar public health impact to RTSS. Furthermore, the feasibility of implementation and the acceptability of R21 is also expected to be similar to that was found in the RTSS pilot introductions. And then, as I've described before, there's no evidence that the efficacy for one vaccine is better than the other due to lack of testing in the same trial. So I'll end this section by highlighting some of the resources that are available to you and the key documents that supported the WHO review of R21. This is mainly the full evidence report for R21. You can access this in the SAGE Yellow Book that you can download at this link. And then this same document also provides data on the grade evidence tables and the evidence to recommendation tables. So next slide. Sorry, next slide. So this is an example or a screenshot of the grade tables, and it's listed as item 7.2 in the Yellow Book. And then next slide. And then this is the evidence to recommendation table listed as 7.2. And this gives a summary of the benefits and harms, the values and preferences, the resource requirements, cost effectiveness, impact on health inequities, and as well as acceptability and feasibility. And so I'll end there and I'll hand over to Rafiq, who's going to summarize the updated WHO recommendation.
Yes, thanks, Lindsay. And maybe just before I go into the recommendation, a bit of a history in terms of WHO recommendation for malaria vaccine. So we can go back to 2016 when the first recommendation was for the pilot programs. So those are the results that Migaiwa presented earlier on. And then fast forward to 2021, we had the first recommendation for the broader use of.
Sorry, Rafiq, I don't know whether it's on my side. You're very faint. I can barely hear you. I'm not sure. Maybe you can try to turn up.
Is it better now?
Much better, much better. Thanks. Thanks.
Sorry, I think the microphone volume was low. So please prompt me if the volume goes down so I can adjust from my side. Is this much better?
Much better. Thank you.
So, yeah, so I'll just trying to take you through where we've been in terms of the WHO recommendations for malaria vaccine, starting with the recommendation for the pilot program in 2016. And then subsequently, we had the pilot programs implemented, and then we had the recommendation for the broad use of the RTSS vaccine in October 2021, based initially on the 24-month results from the pilot programs in Ghana, Kenya, and Malawi. And then in October this year, we've had the review of the evidence for the R21 vaccine. And this is what is going to be presented here as the updated recommendation on malaria vaccines. So essentially, this recommendation covers the two vaccines we currently have. And it recommends the programmatic use of the two vaccines for the prevention of P. falciparum malaria. It's important to highlight that because we do have other Plasmodium species transmitting malaria as well. So it is for the prevention of, sorry if you could go up to the, yes, prevention of P. falciparum malaria in children living in malaria endemic areas, prioritizing areas of moderate to high transmission. I'll come back briefly to the updates regards to where the vaccine can be used in terms of malaria transmission. It's a 4-dose vaccine. Both vaccines are 4 doses provided to children from around 5 months of age for the reduction of malaria disease and burden. We do have additional evidence, especially in areas of highly seasonal malaria transmission, that you do have substantial protection from clinical disease when you deliver the vaccine seasonally. So in areas where you have significant risk of malaria remaining, countries may consider adding a 5th dose a year after they provide the 4th dose. In terms of the delivery approach, I think in the previous presentation, you heard Lindsay talk about age-based. So age-based is, as we know, with most of our routine childhood vaccines, the children receive their vaccines based on age, using the different delivery approaches, whether they get it at fixed clinics, outreaches, etc. There's also the seasonal approach where the vaccination was timed to the high transmission season in areas where malaria transmission was highly seasonal. So that was the results, again, Lindsay provided. We do have evidence for RTSS and R21 used in such manner. So you provide the vaccine doses just before the high transmission season, and then additional doses, again, just before the high transmission season. There is an opportunity to use a hybrid of these approaches. So you are given your first 3 doses by age, either 5, 6, 7 months, but then the subsequent doses, including the 4th dose, are given just prior to the high transmission season. I mentioned areas where these vaccines can be introduced. So countries are advised or recommended to prioritize vaccinations in areas of moderate to high transmission, but they may also consider providing the vaccine in low transmission settings. We'll see a slide subsequently that illustrates that possibility. And the last point is important because with the vaccine introduction, we do not expect that this would replace other existing malaria control tools. Actually, we do expect that this would be used optimally with the other interventions that we have so that we can be able to drive down the burden of malaria significantly. Next slide. So in areas where the malaria transmission is all year round, the vaccine should be provided as a 3-dose primary series starting from 5 months of age, minimum of 4 weeks duration between the doses, just like we have for most of our vaccines. The 4th dose is given to prolong protection, and we've seen from the data that we got from the pilot program, the challenges with the 4th dose. So countries should be flexible with regards to where they put the 4th dose. One, you can look at all the interventions you have in the 2nd year of life, including vaccines and other child health interventions. You can align the 4th dose to those interventions to optimize the uptake. You could also look at providing the 4th dose prior to the seasonal peaks, just like we've seen the benefits in areas where malaria transmission is highly seasonal. There's this question that always comes up with regards to the duration or the interval between the 3rd and then the 4th dose. Currently, we don't have data to support the optimal interval between the 3rd and 4th dose. In the R21 trial, the 4th dose was provided 12 months after the 3rd dose. In the RTSS phase 3 clinical trial, it was provided 18 months after the 3rd dose. But we've seen that in the pilots, the countries have used different schedules. You've seen the impact. Countries have provided a 4th dose from 15 months, which makes an interval of around 6 months between the 3rd and the 4th dose. In Ghana, the 4th dose is given at 18 months, which is 9 months after the 3rd dose. So there's still that opportunity for flexibility. And as we get more data and evidence, I think we'll be able to give a bit more clarity in terms of the optimal interval between dose 3 and dose 4. I've talked about the need of additional doses in areas where malaria remains a significant public health problem, even after children have completed their primary series and then had the additional dose, which is the 4th dose. Countries may consider adding the 5th dose, but I'm sure we'll talk about the feasibility of providing the 5th dose, for example, using an age-based schedule, which is now going to the third year of life. So these should be considered based on local assessment of the data, including the feasibility and then the cost effectiveness. The last point I think Lindsay spoke about, which is the product choice, that we currently do not have any evidence that the two vaccines are different in terms of performance, and the fact that one vaccine outperforms the other, and the decision on the vaccine product choice should be made, one, on programmatic characteristics such as affordability, vaccine supply as well, and then the ability to scale up with that vaccine product choice that the country has made. Next slide. So we've seen a map of Cameroon already with the stratification exercise. This is just to quickly show you how challenging it can be in terms of feasibility of delivering the vaccine when you limit it to moderate to high transmission areas. So you see the blue shaded areas, which are areas of low transmission, around 100 to 250 cases per 1,000 population. And that is interspersed with all these moderate to high transmission areas. So you can see the challenge with limiting the vaccine introduction to the high transmission areas, very close borders with low transmission areas. You would have people moving across. The other considerations as well in terms of political considerations, and then the delivery of the vaccine across these areas, which I mean, really in most places are quite seamless in terms of movements. And when countries decide to introduce the vaccine in low transmission areas, it's very important that they consider the overall malaria control plans and strategy. So you have to go back and look at your national malaria strategic plans and see where this fits in. Cost effectiveness and affordability is also important, always important. And then the last point is about the delivery, which I've spoken about in terms of how feasible or how easy it will be to deliver the vaccine in all areas, including surrounding low transmission areas. Next slide. There are some outstanding questions, just like you have for any other vaccine or new product, that would have to be answered from research. One, and I think we've spoken about this already, not just the two vaccines, but it's important that we do get further data on co-administration with other vaccines that we have on our schedule. So one of the recommendations is the immunological co-administration studies with the rotavirus vaccines, pentavalent, meningococcal, measles vaccine, especially looking at the issues around febrile seizures. We do know that both vaccines have, it's not an excess risk, but there is one of the adverse events, febrile seizures, usually between the first few days after you receive the vaccine. So it'll be important that we get further data on co-administration with other vaccines, especially the ones that also have the potential for febrile seizures. But let me quickly add, I think Lindsay mentioned that based on the review of the safety data, the experts did not find any reason to delay the vaccine introduction based on review of the safety data. It will also be important to look at the evaluation of the vaccine effectiveness in areas of high perennial transmission settings. Lindsay highlighted the fact that for the R21 vaccine, the trial sites were areas from low to moderate transmission. So we go to evaluate the vaccine effectiveness in areas where you have high malaria transmission all year round. There's always a question of a rebound that's not just for vaccines, but for other malaria interventions as well. And one of the recommendations from SAGE and MPAC was for the monitoring of the risk of malaria rebound and the collection of further data on severe malaria and mortality as part of the phase 3 trial, which is still ongoing, and then 4 years of follow-up. And let me add that this is already planned by the vaccine developer. Next slide. Safety always important, and the recommendation is for post-licensure monitoring of safety in infants and young children. And I think this point is already made with regards to febrile seizures and mortality. Mortality might be a bit challenging, and you would have to rely on if you have an existing demographic surveillance system in place, or you could use a community-based mortality surveillance approach as well. The trial wasn't designed to look at efficacy against severe malaria, and so that would be one of the questions that can be answered, for example, using a case control study. And then also I've mentioned the question on mortality already. The last point, and I think this would be one of the questions that people would ask, would be looking at the interchangeability studies for the two vaccines that we have. Looking at the fact that in some countries you would have that period when the two vaccines would be available when they are doing a switch. So it's important to answer those questions on a mixed schedule with the two vaccines that we currently have. And then in order to facilitate and coordinate answering of these research questions, SAGE and MPAC has recommended a cross-department approach in WHO. So this will involve colleagues in malaria, vaccine safety, pharmacovigilance, IVB as well. And this would help us to prioritize as well as to coordinate and monitor the research activities. And then also support in shaping the protocols that would guide these studies. We're currently in the process of looking at the terms of reference for this group, and then we hope the group will be able to convene in the next few months. I think this should be my last slide, and then I'll hand over to Leanne to look at the next steps.
Thank you very much, Rafiq. I realize we're running a little bit behind schedule, so I will go quickly through the last 6 slides, talking about the broader implications of R21 recommendation. So on the next slide, retaking again the slide that Dr. Magafu has shown. So the biggest implication really is that with 2 vaccines now being recommended by WHO, and provided that R21 will receive WHO pre-qualification, we now have higher supply availability. And so basically this means that, for example, among the 18 countries that already have a Gavi application, these countries all of these countries would now be able to move forward with vaccine introduction. Previously, we had to do this very difficult exercise of applying the framework for allocation of limited supply, which resulted in only a subset of approved countries receiving a supply confirmation, and then within those countries, priority to very small subnational areas. So now the good news really is that all countries can think about the scale-up planning. On the next slide, so some of the key characteristics of both products. So maybe starting with supply availability. So RTSS will be available at the rate of 18 million doses for the next 3 years, so quite limited. Both vaccines will be supported by Gavi, the Vaccine Alliance. Countries do not need to reapply if they have already an approved application for RTSS. But what Gavi will try to do is to make sure that the products are allocated in an appropriate way, so that, for example, if a country wants to introduce with RTSS, that country should have the ability to scale up with RTSS doses to all geographic areas in the country. And ideally, a country would not have to use 2 products in parallel. And also ideally, we would want to reduce the need for product switches. So in practice, this will mean that probably a smaller number of countries would introduce with RTSS. And then for R21, given the larger supply volumes, this will allow a larger number of countries to also start introducing, and the larger countries may find it beneficial to start with the second vaccine because of the larger supply availability. There is a product transfer on the way for RTSS to Bharat Biotech, which is expected to lead to higher supply availability in the future. In terms of price, both prices have now been announced through UNICEF. RTSS is currently sold at $10 per dose and R21 at $3.90 per dose. So quite a bit of a difference. We do expect that with higher volumes over time, and with the product transfer, that both prices will come down. So this is the price that UNICEF and Gavi will pay. The price for countries depends on the Gavi eligibility status and the co-financing, which I will cover on the next slide. If we could move to that. So Gavi has a co-financing policy that was slightly adjusted to the malaria vaccine as a time-limited exceptional approach, recognizing that a new vaccine is often more expensive in the initial years of introduction. So in order to increase affordability, Gavi has adopted this exceptional time-limited policy. And so you can see here an example of the 18 countries that already have an approved Gavi application. The large majority falls into what is called the initial self-financing category. So these countries pay 20 cents per dose, and this is irrespective of the product choice. So whether RTSS or R21 is introduced, a country would pay 20 cents per dose each year. And then a number of countries are in the so-called preparatory transition phase. So this is based on income level, a slightly higher income per capita category. These countries start with 20 cents per dose and will see the co-financing obligation increase by 15 percentage points per year. And again, countries in this category do not see a difference in the co-financing for RTSS and R21. The last co-financing group, called the accelerated transition phase, this is the group where there is a difference depending on the vaccine price. And so among the 18 countries already approved, this applies to Ghana, Kenya, and Nigeria. And here, the co-financing obligation is directly linked to the price, starting at 20% of the price in the first year, and then increasing by 10 percentage points over an 8-year period, up until fully self-financing at the end of that period. So for the countries in this situation, affordability considerations and the product difference in terms of price may be more important. And on the next slide, a few additional elements of comparison between the products. My colleagues have covered in the previous slides the comparability in terms of efficacy and safety. So as part of the WHO recommendation, we do encourage countries to inform the product choice based on the broader product programmatic characteristics, including also supply availability considerations and affordability considerations. I will not go through this table in detail, but you will have it as a reference, just to say that a key difference at the moment is that we're still waiting for pre-qualification of R21. The indication for use as well as the schedule is exactly the same for both products. One key difference is in terms of presentation. R21 is going to be available as a fully liquid single vial presentation in two forms. It comes as a 1 dose per vial and a 2 dose per vial formulation. Gavi, we understand, will be supporting the 2 doses per vial presentation, as this will result in a lower cost per dose. RTSS is a lyophilized product. It comes in a 2 vial set. The 2 vials are clipped together, and so this product requires reconstitution. The cold chain temperature requirements are the same for both countries, 2 to 8 degrees. 1 year longer shelf life for RTSS, 3 years compared to 2 years for R21. And then in terms of cold chain volume requirements, slightly bulkier RTSS with 9.9 cubic centimeter per dose compared to what we expect to be 7 cubic centimeter per dose for R21 in the 2 doses per vial presentation. I think we covered the rest, and the fact that we do have much more experience now for RTSS, including in the very large pilot implementation over four years with data from a real world implementation in Ghana, Kenya, and Malawi. So in terms of the next steps, as was mentioned, the broader rollout of RTSS is underway. First vaccine doses have been shipped to Cameroon, and other countries will follow, and we do expect first introductions in the coming months. The different partners are supporting the readiness, different components, and we are trying to really integrate the learnings from the 3 pilot countries in terms of communication, stakeholder sensitization. There are a lot of very good learnings that have been made in the 3 countries. It was mentioned that pre-qualification is a key next step for R21. We do expect that if pre-qualification is granted by the end of the year, the earliest availability at the country level of R21 is expected to be around May to June. And this is due to the different processes that need to be undertaken in terms of supply confirmation, ordering, but also the Gavi support process steps. So some key next steps for countries that have already an approved application. Those countries that have not yet confirmed an RTSS introduction are invited to express a product preference to Gavi, which will then be considered in light of the volumes that are available for each product, and also other considerations, for example, the affordability, the co-financing requirements, and so on. Countries are now also invited by Gavi to submit scale-up plans that go beyond the very limited first phase approvals that were given in the last couple of months. We would encourage all countries to organize these scale-up planning processes in collaboration with the appropriate programs at the country level. So ideally including the EPI and the malaria control program, so that the vaccine scale-up can be considered in the context of the overall national malaria control strategy. And then finally, countries that have not yet had a chance to apply for malaria vaccine support from Gavi can do this in the upcoming rounds. There are typically 4 application opportunities per year. And then non-Gavi eligible countries may access the vaccine directly via UNICEF or directly from the manufacturer. And as supply has now the expectation of a supply increase starting next year is a reality. So this is now really a possibility for additional countries. On my final slide, we would just like to highlight a few of the technical resources that are now available. It was mentioned that you have access to the full evidence reports for both RTSS and R21 on the links that are provided here. These include grade tables and evidence to recommendation tables. We have also an advanced draft of a guide for introducing a malaria vaccine into national immunization programs that includes a lot of the lessons learned in the pilot countries. We have a generic training slide deck that can be adapted at the country level. There are communication and demand generation materials, again, for adaptation at the country level. And there is an introduction readiness assessment tool. And so with this, I think we're at the end of our formal presentation, and we'll be very happy to take questions.
Thank you so much, Eliane, Rafik, Lidse, and Mugawa for excellent presentation that you've covered pretty much everything on malaria vaccine, at least what is critical needed for this webinar. And now we're going to invite NITAGs and other participants in this webinar to engage with the speakers. So for the next 30 minutes or so, we're going to have question and answer session. I think Salim and the team have been kind to collate some of the questions typed on the Q&A box. So maybe, Salim, if you can project for us what you've managed to collate. But as you do that, oh, there we go. So this is a question from Dr. Nyanda Elias from Tanzania. Any reason for the systematic decline from the first dose to the fourth dose in almost all countries, apart from the calamities in Malawi and stockout? I think this is directed to Mugawa. Do you want to answer this, Mugawa?
Thank you, Ben. We have seen in the 3 pilot countries that the coverage of antigens that are given in the second year of life doesn't really, get it to a high level. And you will recall that the fourth dose for the malaria vaccine in these countries, for most of the time, it's been given between 22 months of age up to 24 months of age. So, going into the third year of life. So we don't really expect that, the coverage of the fourth dose, which is given in the third year of life, to be higher than the coverage of the antigens of the doses that are given in the second year of life. So it's sort of expected, but we have also learned that when countries, do some intensification of routine activities, there's a tendency of the fourth dose coming up, and once they stop, that goes down again to where it was. So yes, there will be times when the countries will need to come in, conduct periods to make sure that the coverage of the fourth dose increases. That's what I can say at the moment.
Thanks. So I mean, it has been observed a similar trend with routine vaccines. The further away you get from birth, the less the coverage, and that's why Immunization Agenda 2030, one of the strategic goals is to strengthen primary healthcare, because it points to programmatic challenges that prevent high coverage as children get older. All right. There is a raised hand from Adam. So Adam, let's first go through all the typed question in this presentation, and then we'll come back to you. You'll be the first to be given the floor. All right. The next question is on effectiveness data against malaria next to the reduction on all-cause mortality in Kenya, Malawi, and Ghana. I think this is also for you, Magafu, or also it could be for Lidze. You should, no, that's for you, Dr. Maguire.
Yeah, the question is not clear enough to me. The data that we have shared regarding, all-cause mortality reduction in the 3 countries, they pertain to effectiveness of the vaccine, because this is the implementation of the vaccine in the real world out there, not in a trial. So those data for effectiveness of the vaccine in the 3 countries, Kenya, Malawi, and Ghana. Now, next to reduction, that next really is not clear to me.
Yeah. So Maguire, was the data able to tease out between all-cause mortality reduction and malaria specific related mortality?
Yes, the 13% is actually the contribution of the vaccine to all-cause mortality. So it's on top of the other interventions that are there. So it's an additional reduction.
Okay. Maybe Dr. Nyanda, if the question is not clear, you can unmute yourself and just clarify that to Magafu.
Ben, before Dr. Nyanda comes in, can I add on to Dr. Mgaiwa's answer?
Sure.
Yes. So the evaluation was, so first of all, the pilot implementation and evaluation was set up to look at the pooled estimate across the 3 countries. So the design was, one, not to look at the estimate for each country. In addition to all-cause mortality, so this is all-cause mortality, and like Dr. Mgaiwa said, on top of other malaria, impact of other malaria interventions that were already there. So this is all-cause mortality, excluding deaths and injuries. That's with the 13%. In addition, we do have other endpoints. One was on the impact or the effectiveness against severe malaria. And after 46 months of evaluation, again, this is a population level evaluation, given the coverage that we currently have. We saw a 22% reduction in hospitalization with severe malaria and a 17% reduction in admission with a positive malaria test. So these are additional data points aside the reduction in all-cause mortality. So there is a substantial reduction in severe malaria, as well as reduction in hospitalization with a positive malaria test.
Yeah.
Thanks for that.
Thank you, Rafik.
Thanks, Rafik, for that addition. Right.
Benjamin.
Yeah.
Hello.
Hello.
I think Benjamin covered what I wanted to hear. That what are the other severe and other endpoints? I think maybe I missed it. I just saw all-cause mortality being reduced by 13%, but I think I might have missed what Rafik actually profoundly shared. That's what I needed, apart from the all-cause mortality reduction, other endpoints, which I think Rafik was able to clarify. Thank you.
Right, great. All right, thank you. Next. So, hello, thanks for sharing this malaria vaccine progress, great impact result, the 2 vaccines. Is there experimentation to use mRNA technology to develop them? I presume this is malaria vaccine. Secondly, I see 13% reduction in mortality for RTS from a programmatic perspective. What is the recommendation on malaria treatment guidelines with other interventions such as ITA and ACTs from the cost-effective perspective? I think that has been partly covered in the previous question, except the malaria guideline. But who wants to take the question on using mRNA technology to develop malaria vaccines?
I'm happy to answer that.
Yeah.
So there is some work on mRNA for malaria. It's in very early stage. So there is one candidate being developed by BioNTech, and it is using CSP. So it's the same antigen that's used in RTSS and R21. That only entered phase 1, first in human studies December last year. So we haven't had initial data on that. And that first study will only be looking at safety, I think in adults, and maybe some initial immunogenicity data. But we are hopefully monitoring that space and we'll see some developments there. The efficacy of R21 vaccine, you'll also be able to see that in the slides provided later. But for seasonal administration, it's 75% 1 year after dose 3. And then in age-based schedule, it's 66% 12 months after dose 3.
And Ben, just to add on that second point on the what it means for malaria treatment guidelines, I think we emphasized that in the presentation, that the vaccine should not replace existing malaria control tools. We do expect that countries would continue to use ITNs in places where they deem fit. And of course, usually use of ACTs are across all areas in country as well. So the vaccine would not replace any of these interventions. It should complement or be integrated into the existing malaria interventions in the country.
Okay, thanks, Rafik. Jane will come to you, unless if you want to add on to the discussion around treatment or mRNA, Jane?
Ben,
I just want to ask a question. I'll wait.
Okay, please wait. We go through the questions that are projected on the slides, and then we'll come to open session. Right. So the other one is why 3 and 5 years data not available? Is that not too long? Not quite sure which data this is for. Does any of the speaker know what this 3 to 5 years data refer to?
I think that might be referring to the comparison of the RTSS and R21 seasonal data. So it's mainly that the study started at different times, actually. So the seasonal administration for RTSS has just been running longer. And so there is data for up to 5 years. The R21 vaccine was recommended with data from 12, and we had some data on 18 months. The study is still ongoing, so it will continue up to 4 years of follow-up. So we will get that data. One of the reasons why we went ahead with the WHO recommendation without waiting so long is one, the high demand for malaria vaccine, but two, that we were seeing quite similar efficacy. So we felt that that data at the time of R21 was sufficient to move forward with the policy recommendation.
And Lindsay, if I may just have a follow-up question to that. In terms of immunological responses, do we know what is related to efficacy that is being observed? Can you rather say that we do have correlate of protection? And if yes, how does that compare for the two vaccines?
Sure. There have been a lot of studies trying to relate the antibody response with protective efficacy. There have been varying results. It's very hard to see a consistency in that data. So we do not have a correlate of protection for malaria vaccines. And there is ongoing work to look at different types of immune responses if it can give us more data. But WHO is interested in holding a technical consultation probably next year to look at the state of the evidence on correlates of protection. I think the next stage in that area will be to align developers to see what data they need to provide that regulatory agencies would be comfortable with immunological data as a correlate. But I think we are some years away from that.
Okay, great. Thanks. Right. Next, thank you, Rafik. In case a country choose an hybrid vaccination, I take this means R21 and RTS, which combination will produce an optimal result? Rafik, this is addressed to you.
Hi, sorry, I was muted. So I think that the question is on the, maybe we'll get clarification whether it's asking about two vaccines, but if I get it, is looking at the delivery approaches. So I talked about the hybrid approach, which is providing your primary series, the first 3 doses, using an age-based all year round, just like children will receive their other routine vaccines. And then the difference is how you give the fourth dose or the additional dose. So the fourth dose is provided just before the peak transmission season. So here you are giving your fourth dose not based on age per se, but based on time, because you are giving it just before the peak transmission season. And this is an alternative approach to delivering all doses timed seasonally, because we know that would probably involve giving your doses through a vaccination campaign with all the logistics it requires. So that hybrid approach might be more feasible. And so children can get their first 3 doses, it could be 5, 6, 7 months. And then the following year, just before the peak transmission season, you give an additional dose a month before the peak transmission season. And let me quickly add that that's where there's also the other recommendation that in areas where you still have significant risk of malaria transmission, there is a possibility to consider a 5th dose and to provide an additional protection. And we've seen from the data from highly seasonal transmission areas that you are able to get very significant protection from clinical malaria through 5 years.
Okay. Greg, do you want to?
Yeah, it's in a way related to what Rafik was saying. So Rafik, I mean, there's no evidence at the moment for interchangeability, but given the reality on the ground in terms of the shortage of the vaccine, what would be a possible recommendation?
So thanks, Greg. I think that is also contained in the current recommendation that yes, it's true. We do not have any evidence in terms of interchangeability for the 2 vaccines. But if you look at the 2 vaccine constructs in terms of the targets, even the adjuvant and the mechanism of action, I mean, biologically, there's no reason to think that they would behave differently. So the current recommendation advises that one, yes, it's for countries, it's important that you are able to scale up with one product in instances where there's a switch and children have already started on one product, especially for, let me say, for RTSS, which has already been introduced. They can complete their vaccination series with the R21 vaccine. But in all instances, the guidance is to try as much as possible to let the children complete their, in the absence of the evidence, complete their vaccination with one product.
Okay, great. Thanks, Rafik. Next, right. Just to ask about the capped 1 million for 2023-2025, as explained above. Will this not pose problems for country using 18 months co-administration to increase coverage, like Ghana, as well as aiming for pre-seasonal peak transmission? Ramonde, do you want to unmute yourself and just clarify this question? You're talking about the age and the timing of the vaccination. Ramonde?
Yes, Prof. Hi, thanks. So I was just asking about the RTS dose, sort of dose amounts as 1 million per country for 22-23. And so if, like we just spoke about now, there is this age-based timing to start with, and then there's a recommendation to actually give dose 4 just before there's a seasonal malaria peak, and possibly to co-administer it like they did in Ghana with the MR2 at 18 months of age to increase the coverage, which seems like a really good way to keep that dose 4 intensity up. I'm just concerned about countries who now do start on one type of vaccine schedule. What happens to their next year's cohorts of infants needing doses 1, 2, and 3? It just seems like there might be serious stock issues that could threaten the program and create a lot of catch-up doses that could be problematic.
Eliane, do you or Magaf want to answer that? Okay.
Yeah, I can try to have a go, and then maybe Dr. Magafu wants to complement. So the allocation to the countries based on the framework for limited supply has taken account of that in a way to anticipate that, to be able to cover the entire cohort in an area that has started with the vaccine. Taking the example of Ghana, given that Ghana has started implementing the vaccine as a pilot, a key principle in the allocation was to enable Ghana to continue offering the vaccine in those areas and avoid the disruption. And so the calculations that were made including by Gavi, ensured that sufficient vaccine was allocated to Ghana to allow all age-eligible children to receive the vaccine. And then if some were late, they would have vaccine doses later if they are caught up through PIRI efforts. So that was all taken into account in the supply forecasting and allocations.
Okay, great, thanks. Let's go to the next question. Salim, is that all from the...
They are more in the current Q&A box, but that's all that...
Yeah, so let's take from Adam. Adam had raised his hand earlier, and then followed by Jane. Adam, do you want to unmute yourself and ask your question or make a comment? Adam. Okay. Adam Omar, I see you still on mute. Okay, maybe as you wait for Adam, Jane, do you want to go for your question or comment?
Hello, are you hearing me?
Thank you so much.
Okay, Jane, let's take Adam. Adam, go for it. And then after that, Jane will come.
Yes, I am Dr. Adam from Sudan. Thank you very much for this opportunity and very informative presentation. Thank you for all speakers and all presenters. This is very nice information, but my question is the adverse event following the immunization of the malaria vaccine. Is it depend on age or any immune system of the individual, or it is general to all individuals? And if there is any contraindication or not? Thank you very much.
Okay. Lidse, do you want to take that on immune responses? What are the determinants on how we respond to malaria vaccines?
Yeah, sure. I can speak to R21. I think it's similar to RTSS, but maybe Rafiq or someone else wants to add. For R21, the only major safety association, it was associated with febrile convulsions, and that was also observed for RTSS. And that attributable risk is 1 per 2,800 doses of the vaccine administered. And that is actually in a similar range to other childhood vaccines that have been routinely used. So RTSS actually, as the starting example, has a risk of 2.5 febrile convulsions for every 1,000 doses. And then measles is 1 per 2,000 to 3,000 doses, and also very similar to DTP vaccines and PCV vaccines. So it has been recognized, but that was not a reason to delay the recommendation or deployment of the vaccine. And in terms of immunogenicity, we haven't seen data looking at the correlation of the age of the individual or immune responses in relation to the adverse events, but it's a fairly small age cohort. So,
thanks, Lindsay. All right, Jen.
Thank you so much. Mine is on the arm where that was tagged on SMC. I just wanted to understand why a higher efficacy. Was it related to better coverage compared to the age-based? Could it be because it was SMC and there was a platform for us to reach more children, that there was better coverage? Was it because of the timing? Because since it's pre-season, you give it to the children before the season and before the season of high transmission. So hence the high efficaciousness. That is what I want to understand, because, you know, these are some of the things we may use as reference when we're trying to draw effective rollout plans. Over to you. Thank you.
All right, the issue of seasonality and efficacy. Rafiq or Lindsay, please go for it.
Sure. I think there's two reasons why you will see differences in efficacy. So the seasonal administration has a really big effect. So again, that's for both vaccines, you get the highest level of protection in terms of immune response and actual clinical protection seen in the data in the months right after you administer the vaccine. And then that protection starts to wane over time, even within 1 year, which is why we recommend giving a 4th dose. In seasonal areas, if you time that primary series right before children will have the highest malaria challenge, you're really maximizing the effect of that highest vaccine protection. So that's one reason why we see higher efficacy in the seasonal administration. And then when you measure that efficacy after they receive the doses is also important due to the waning efficacy. So if you measure RTSS and R21 12 months after the primary series, you'll see quite a good efficacy, and then some variation between seasonal and age-based. But if you measure at 3 and 5 years, of course, we'll see a waning in protection. So I think taking into account both of those factors when looking at the efficacy data is really important.
Thank you so much, Lindsay. I know Stephen is here from Gavi, and Stephen, one of the issues that routinely comes up is about the requirement for NITAGs. The requirement from Gavi when it comes to NITAG submitting a recommendation. And I remember for the RTSS, there was a rush by NITAGs to make a recommendation. Is it the same with R21, and what's Gavi's position on that in terms of the role of NITAGs? Stephen?
Benjamin, I fear that Stephen had to drop off. He was with us for some time, but I think he had to drop off.
Oh, okay. All right. He was only with us for 30 minutes.
Yeah, exactly. He had a hard stop.
All right. Okay. But Elaine, any insight into the Gavi's requirement when it comes to supporting R21 rollout? Or NITAG recommendation is not required in that case?
Yeah, so in general, it's a Gavi principle for new applications to solicit a NITAG recommendation for the use of the vaccine. So for countries that have not yet applied, that would be an encouraged step. Now there are, for this question about the product preference, there is a quite tight timeline because Gavi wants to make sure to be able to allocate as quickly as possible the vaccine products to the countries that already have an approved application. And so for the product preference expression, it's not a requirement to have a NITAG recommendation, but some countries may wish to do so to inform their product preference.
Okay, thank you so much, Elaine. So I think now we're going to move to the last part of the webinar. And again, thank you so much to all the presenters. Suzanne, are you going to give a brief 10-minute presentation on the NISH or NITAG Support Hub library guide on malaria?
Yes, that's what I'm going to do. I'm going to share my screen for a brief presentation. If I can find it. Can you see my screen?
Yeah, we can see your screen.
Okay, good afternoon, everyone. My name is Susanne Noll, and I'm the librarian or information specialist at VACFA and for the NISH project. My task today is to introduce you to the library guide created by NISH on malaria vaccines. We do have several library guides on different topics and plan to extend those as the vaccine research expands. What are library guides? As the name indicates, library guides are typically used to collect and display subject-based or discipline-based resources for a specific audience, which you all are. The best library guides are user-focused and provide advice for finding more information, as well as linking directly to resources. So you will find the library guide or LibGuide on the NISH website, which is health.uct.ac.za/NISH under Assets and Resources. So if you do your own searching, you will find the library guide on malaria in Africa. Library guides were created by NISH for you to have a quick and easy access to scientific literature. Once you have located the library guide on malaria vaccines, start inspecting the different tabs. You will find the Home tab, the Books tab, the March 22 WHO malaria position paper, several articles on malaria vaccines in sub-Saharan countries. I could find articles that were published in Ghana, Nigeria, and Kenya. You will also find articles from literature from PubMed, EBSCOhost, Scopus, and Web of Science, and the latest publications on malaria vaccine AS01, and also on the malaria vaccine R21 matrix M. On the Home tab, you will find a general introduction and some introductory literature on malaria in Africa in general. And as you can see, all African countries are always taken into account when searching through scientific databases for literature. Databases searched are usually PubMed, EBSCOhost, Scopus, Web of Science, and Google Scholar. Under books, you will find a list of books available at UCT libraries, and you can order them through me via our interlibrary loan services, should you be interested in any of these books. On the third tab, you find a reference to the WHO position paper on malaria of March 2022. As you know, WHO publishes vaccine position papers that provide global vaccine and immunization recommendations for diseases that have an international public health impact. The papers summarize essential background information in the WHO position paper on their global use. The papers are reviewed and updated periodically by WHO based on new scientific evidence and public health priorities. All the references that have been used in this position paper by the WHO have been extracted and, by way of sorting them alphabetically, made available in this tab with its links to the full text. This is what it looks like. If the full text is not available, it is indicated with not open access, but still can be obtained by contacting this librarian. So the latest contribution from the WHO on malaria vaccines is the WHO weekly epidemiological record of 24 November 23, which was just last week. So there's a lot of latest information, probably also what you reported earlier in this webinar mentioned in that epidemiological record. This is what it looks like. Here you can see the alphabetical order of all the articles that have been used for the position paper. And you can see that not open access, but you have always got me to get those for you, should you be interested, or you will find a link to the full text of those articles. You will also find maps in various tabs, as this one on malaria morbidity in countries in sub-Saharan Africa, or the estimated impact of RTS as AS01 vaccine allocation and strategies in sub-Saharan Africa. And references to these maps are extracted from scientific articles and databases such as Scopus and Web of Science. The three tabs on Ghana, Nigeria, and Kenya indicate that most research publications at the moment on this topic of malaria vaccines are stemming from those three African countries. The last two tabs are indications of literature on the two malaria vaccines that were published recently, including unpublished documents by the WHO and SAGE. Thank you. This is all what I have to say for this afternoon, and I'm happy to answer any questions. And you can also contact me at this email address should you be interested in more or different articles. And I'm also welcoming any suggestions which you think should be included in a library guide like this. Thank you.
Thank you so much, Suzanne, and we do really appreciate the work that you do in terms of supporting NITAGs to find the evidence in a timely manner. So please, if you have a question or want some guidance from Suzanne in terms of how you can access evidence, especially local evidence, which sometimes it's always a challenge, and also navigating multiple databases, which often is challenging, especially if you don't have the skills that librarians do have. So we're coming to the end, and before I just thank everybody and the speakers, particularly Sidi, do you want to make a comment around the evaluation for the training that WHO and partners have done for NITAGs?
Thank you, Ben, and thanks again for the NITAGs members in participating in this webinar, but also the colleague from Afro and HQ, and also the NISH, who is really doing a very good job in supporting the NITAGs in the region. So, as you mentioned, since 2 years now, we are training the NITAGs on the NITAG operation, on the NITAG function, but also on vaccinology training and evidence recommendation process. So we want to do a survey for the NITAGs. So we will reach to you by mail. So to the countries which we train in 2022 and 2023, and some of them are here in the call. So next week I will probably send you the link for the survey. Really to fill this form. It will take between 15 to 20 minutes to complete the survey. And this can help us to improve the training in there and its different aspect. So thanks again. Maybe Ben, if you want to compliment. Over.
No, I think you've covered everything on that, CD. Just the feedback, even for these webinars, always helps us in terms of making the training experience much more better and much more effective. So I see we've got 4 minutes left, and there are some questions that have been put onto the Q&A. Are our speakers still there? Dr. Marufu, Elaine, Rafik, and Lindsay, are you still there? Are there some questions that you've got bandwidth to take more questions?
Yeah, I think we're still here.
Yeah, we are here.
I see there's one question that I can maybe try to address, since we're working very closely with Gavi on these next steps. I can talk about the question from Dr. Amina Abdul-One. She asks, for countries that already got an approval from Gavi for RTSS and want the R21 vaccine now, can the countries change their decision? And if they can, do you have an idea of the timeline for this change? So it's a very good question. It depends a little bit at what point in the process each country is. For example, we have some countries that have received a supply confirmation back in July for RTSS, and that have now confirmed that they would like to move forward with RTSS. So an example is Cameroon, where the first shipment has arrived in the country already. So in that setting, we would expect the country to move forward with RTSS, and the switch would not immediately be envisionable. Then there might be other countries that have not yet formally, let's say, accepted that RTSS allocation, and that may want to consider R21 as a preferred product. And this is now a good moment to express that product preference. Gavi has invited the countries that are in this situation to respond to a product preference request. And the deadline is fast approaching. It's actually the 1st of December. Ideally for Gavi to receive these expressions of product preferences. And then what will happen at the Gavi level is they will look at each country's preferences and look at what the forecast might be for these needs, and then compare this with the supply availability for each product. And then in the ideal situation, each country can receive its preferred product, but there might be a situation where the first preference cannot be met, simply because there's not enough vaccine available of one particular product. And in that situation, Gavi has reflected on some criteria that could be used to inform the product allocation. And one of them, for example, is the ability to go to scale with a single product. So ideally, Gavi would confirm a certain vaccine for a certain country, knowing that that country can also go to scale if they want to. Another consideration is the affordability. So I mentioned countries in the Gavi accelerated transition phase in terms of co-financing. They will be directly subject to the price difference of the vaccine. And so for these countries, they may be given preference to the lower cost vaccine, and Gavi would take that into account.
Thank you, Elaine, for that detailed and comprehensive answer. So we're coming to the hour, and just to thank you so much, our speakers from WHO, Elaine, Rafik, Lindsay, and Marufu. We really appreciate. And also, Suzanne, I can see a question about somebody asking how they can access the library guide. So please reach out to that person. And just to check with Elaine and the team, is it okay if we share those PowerPoint with the NITAGs?
Yes, absolutely. I think we made one last change compared to the deck we sent you already. So we will send you an updated version, and that can be shared. And I'd just like to take the opportunity on behalf of the malaria vaccines team, WHO, really thank you for this opportunity. And we remain available should there be any questions.
Excellent. Thank you so much. We appreciate. And to you, NITAGs and other participants, we really appreciate your time, and hopefully this was useful. The idea is to provide a forum for you to get up-to-date information on a specific vaccine-related issue that is topical, and in this case, it is malaria. I was just telling Eliane that 2023 seems to be the year for malaria vaccine development. So thank you so much, and just to let you know, we're going to have the recordings of this webinar available on our website. You can go and have a look and download, and also the previous webinars, you've got access to them. So thank you so much. Take care and have a wonderful day. Bye-bye.
Thank you very much.
Thank you, Benny, and the